Are you able to share? I don't see Libukhang.
I'm trying to share the attachment now, Prof.
Okay, are you winning?
Just give me a moment.
Yep, you look like you are. Sounds. Sorry, let me just stop this. Okay, you ready to go, Libukhang? Are you not able to share?
I'm not able to share it. It doesn't want to share PowerPoint.
Now, if you open your PowerPoint on your desktop and then open the screen share screen, and then just look around to see whether you can make out PowerPoint. Hopefully you haven't got a whole lot of other things open on the desktop. I thought I saw you winning just now.
Yeah.
Yep. Okay. Please avoid doing this on a phone. I think that's challenging to your colleagues. Try and get to a laptop when you're doing this. All right, proceed.
Okay, so I'll be giving a presentation on HIV adult in the primary healthcare system. So basically, I'll be defining what HIV is, the pathophysiology, the clinical presentation, how we diagnose it, how we initiate treatments, and the investigations that we do, how we manage it. So HIV is an RNA virus belonging to the family Retroviral. It is transmitted through contact with blood and or bodily fluids, through sexual intercourse, sharing of needles, perinatal transmission, needle stick injuries in our setting, etc. And then the virus basically infects cells that are involved in the immune system. So your CD4 T cells, macrophages, and dendritic cells. And then the infected CD4 count, the infected CD4 cells initially increase in response to the infection and then decline over time. And then this makes the body susceptible to opportunistic infections, and then eventually this leads to the development of AIDS. So the people that we see, the HIV people that we see at the clinics, could be newly diagnosed or chronic patients that are already on treatment. So the newly diagnosed patients would be patients that were seen by counselors, where they do the voluntary counseling and testing. They usually go out and find patients, or they find random patients and ask them to come test. And then if there's any concern with regard to starting treatment or patient consent, they might refer them to us. And I've encountered quite a few patients who come in and they say they want a HIV test because they are concerned because they had engaged in activities that may have exposed them, and other patients unfortunately were victims of sexual assault and things like that. And then we might also find it incidentally while we work our patients for signs and symptoms of immunocompromise. And then in terms of chronic patients, so follow up when they have come to collect their medication, and then patients that have defaulted treatment are referred to us as well. And then usually to review abnormal blood results and see if we need to dose adjust or change the medication. And then if patients have virological failure. So when you see these patients, whether they're acute or chronic, you need to screen for symptoms of TB and also symptoms of an STI. And then it also serves as an opportunity to promote health, because you can ask them about their partners and if there's safe sex practices between the two of them. And then you also have to screen them for substance use disorders. And basically your history and your examination is aimed at classifying the patient according to the WHO clinical staging. So stage 1 would be an asymptomatic patient with generalized lymphoedema. Stage 2 is moderate weight loss of less than 10% of the previous body weight, and it is dermatological manifestations. So herpes, recurrent oral ulcerations, seborrheic dermatitis, and fungal nail infections. And then if there's recurrent respiratory infections, so sinusitis, bronchitis, otitis media, and pharyngitis. And then stage 3 would be weight loss of more than 10% of the previous body weight. And if there's unexplained chronic diarrhea, persistent fever, oral candidiasis, hairy leukoplakia, and pulmonary TB in the last 2 years. And then stage 4, which is AIDS defining illnesses, you get HIV wasting syndrome, PJP pneumonia, and then you get recurrent severe bacterial pneumonia, chronic herpes simplex, esophageal candidiasis, extrapulmonary TB, Kaposi sarcoma, and central nervous system toxoplasmosis, and HIV encephalopathy. So the way you diagnose it is that you do a rapid test, and if it's negative, you treat it as negative, you counsel the patient, again, regarding safe sex practices, and advise them to come back and test again in 3 months' time. If the test is positive, then we repeat the rapid test using a different testing kit. And then if it's positive, then the diagnosis is confirmed. And then if it's negative, then you'd have to actually pull bloods and send for an HIV ELISA. So once the diagnosis is confirmed, you first have to check if the patient is eligible to commence antiretroviral therapy right there and there, right? I think previously, a long time ago, you had to pick and choose who can start treatment or not. But now it's everybody, regardless of CD4 count and WHO staging, is eligible to receive ART. The difference is that you might need to delay it in certain people. So in people without contraindications, you aim to start immediately if the patient is understanding and willing to start the treatment right there and there. And then in patients with substance abuse disorders, or patients who are struggling to accept the diagnosis, or patients that are unsure of whether or not they want to actually start treatment, you counsel and then bring them back and aim to start the treatment within 7 days. So in patients that are, you cannot start ART in immediately, it would be a patient who has TB symptoms. So cough, night sweats, fever, and recurrent weight loss. Recent weight loss. So in such a patient, you would first need to investigate for TB. So you do a sputum GXP. And then if the patient is GXP negative, then you would offer the ART and then give TB preventative therapy. And then if TB is diagnosed, right, which we move next to the next point there, if it's a drug-sensitive TB at a non-neurological site, then the CD4 count is less than 50, then you initiate ART after 2 weeks of starting the TB treatment. And if the CD4 count is more than 50, then you initiate ART 6 weeks after starting the treatment. And if it's drug-resistant TB at a non-neurological site, you initiate ART after 2 weeks of TB treatment. And if the diagnosis is drug-sensitive or drug-resistant TB at a neurological site, then you defer treatment for 4 to 8 weeks. You defer the initiation of ART for 4 to 8 weeks after starting the TB treatment. And then in patients with signs and symptoms of meningitis, you have to investigate the meningitis before starting the ART. So patients who are clade positive, in the absence of symptoms or signs of meningitis, you defer the treatment for the first 2 weeks of fluconazole prophylaxis. And then in patients that have confirmed cryptococcal meningitis, you defer ART for 4 to 6 weeks until antifungal treatment has been completed. And in patients with other acute illnesses like PCP or bacterial pneumonia, you defer treatment for 2 weeks. And then if there is clinical signs and symptoms of liver disease, you have to pull bloods to check the ALT. If it's more than 120 and the symptoms of hepatitis, then you have to investigate the possible causes. So then you have to exclude hepatitis, exclude drug-induced liver injury, or alcohol abuse. And then if the patient is already on ART and then you discover any of those diseases, then you just start treatment. You don't need to stop the ART. So the investigations that you would do in a newly diagnosed patient, we do a CD4 count. And then this helps us in determining whether or not the patient has to be put on PCP prophylaxis, and also helps us with regard to the prognosis. And you would also screen for pregnancy, screen for TB as well, screen for STIs. And then other blood tests that you would do is FBC if you're going to be using an AZT, a regimen with AZT, and then creatinine if you're going to be using tenofovir, and then ALT if you're using nevirapine. And then the guidelines say that you don't do the viral load immediately in a newly diagnosed patients because you assume that it's going to be high. So you would wait 6 months and then do the viral load. So then in chronic patients, you repeat the CD4 count after a year, and then this will help you monitor the response to the HIV treatment, and then whether or not you need to stop prophylaxis. And then you'll do the viral load at 6 months, at a year later from diagnosis, and then every year after that. And then so this then will help us see if there is virological failure, if there is non-compliance. And then also, if depending on which drug you'll be using, you'd continue monitoring the FBC, the creat, and the ALT. And then if you're using lamivudine and ritonavir, then you would have to test cholesterol and triglycerides. So then management, pharmacological management. Currently, we are switching from a TEE, which is tenofovir, emtricitabine, and efavirenz-based regime, to TLD, which is including dolutegravir and lamivudine. So to swap the patient, you have to counsel them extensively, and it has to be a decision that the patient makes. In adult women, you have to look at whether or not the woman is childbearing, if they're already pregnant, or if they want to start a family soon. And that will help you determine what you want, TLD or TEE. Yeah. So if the woman is not pregnant but desires fertility, then you would give TEE because there's a concern with regards to dolutegravir and neural tube defect. And then if the woman does not desire fertility or is older, then you would give TLD. Or even in a childbearing age female, you could still give TLD, but then you'd have to put them on a contraceptive as well. And then TLD is recommended in adult male. So then switching the patients from TLD to TEE. Hello?
I think that, please, you using the word switching, please understand that it's switching from where people were before, which was original first-line treatment, to TLD and TEE as options. So TEE is an option of, so in other words, if a patient is of childbearing age, then they're going on to TEE. When they are finished, you then want to move them back onto TLD because that's your choice as first-line treatment. Just to clarify, I'm not sure that others feel clear, but just clarifying that. Carry on.
Okay. So then with regards to the viral load monitoring, if the viral load is less than 50, you would provide the person with information with the risks and benefits of dolutegravir and the use of contraception. And then if it's 50 to 1,000, then you would repeat the viral load in 3 months' time. And if it's still the same, again, provide information on the risks and benefits of dolutegravir. And then if the viral load is more than 1,000, then you would not switch to dolutegravir at that moment. So dolutegravir is an integrase inhibitor. The dose is 50 milligrams for patients weighing 35 kg or more or older than 10 years of age. The side effects are insomnia, headache, GIT symptoms, weight gain, increased creatinine levels initially, and then there's also the concern about neural tube defects. So from what I gathered when reading about it, they wanted to use dolutegravir because it has a better side effect profile compared to efavirenz. So then the benefits of dolutegravir would be that it provides rapid viral suppression. It has a high barrier to resistance, does not interact with hormonal contraceptives, and as I mentioned, the side effects are mild and uncommon. And then the risks, again, neural tube defects, and then it has, I think, multiple drug interactions. And then with regards to efavirenz, it has a low genetic barrier to resistance, and then it interacts with contraceptives, and then it causes neuropsychiatric side effects. The benefits would be that it is safe in pregnancy, and then it does not interact with TB treatment. So as I mentioned, dolutegravir reacts with quite a lot of drugs. So for patients on rifampicin on TB treatment, the rifampicin decreases the dolutegravir, so you need to double the dose. So then you give 50 milligrams 12 hourly. And then if the patient is on a fixed dose combination, then you would give the additional dose 12 hours after the FDC. And then in patients using antacids, multivitamins, or other supplements, they also decrease dolutegravir. So then again, double the dose. And then in anticonvulsants, carbamazepine, phenobarbital, and phenytoin, they also decrease dolutegravir. So same thing as above. And then metformin increases, dolutegravir increases metformin levels. So then you would have to cap your metformin dose.
That's right. Okay. Now I just want to help you along. Reduce the doses of metformin.
Yes, so you'd have to reduce the doses of metformin and keep them at 500 12 hourly. So second line treatment is given when there is proven virological failure, or if the patient is not tolerating any of the side effects from the first line treatment. So to prove virological failure, the patient has to be compliant on the ART, I think for 3 months, if I'm not mistaken. And the viral load still has to be high after that. So then there is an NRTI based regimen and INSTI based regimen. So then the first one would be tenofovir, 3TC, FTC, and EFB on verapine. And then the second one would be tenofovir, 3TC, FTC, and dolutegravir. So in terms of going to third line treatment, then you would have to refer the patient, and then there has to be resistant testing that is done before we can switch between second line and third line. And then there's dose adjustment that may be needed for certain drugs if there is renal impairment. Tenofovir should be avoided. And then if you're still using the TEE, you can dose adjust for emtricitabine. So then you would give the dose every 2 days or every 3 days or every 4 days, depending on your creatinine clearance. And the same for lamivudine. You can half the dose if the creatinine clearance is 10 to 50, and if it's less than 10, then you give 50 milligrams. And then zidovudine, you would, if the creatinine clearance is less than 10, then you would give the dose daily instead of 12 hourly. So in patients that have defaulted treatment, you have to make a thorough assessment of the patient. So determine which drugs they were on, how long were they taking them, were they working, and also explore the reasons why they decided to actually stop taking their treatment. And if it's due to side effects, and if there is no recorded viral load, then you'd have to obviously ask the patient if they know of the actual values or not. And if the patient was well on the first line regimen and they were tolerating the side effects and they were virally suppressed, then you restart the first line regimen they were on, and then you repeat a viral load after 3 months. If they are not suppressing on that, then you provide enhanced adherence support and repeat the viral load after 6 months. And then if the viral load is less than 1,000, then you can offer a single drug dose to a single drug switch to dolutegravir. And if the viral load is more than 1,000 at 6 months, and then you manage it as virological failure. And then if the patient is ill, consider a new regimen, and then you would consult specialists on that. And then, so prophylaxis. So in patients with a low CD4 count, less than 200, WHO stage 2, 3, and 4, you give them prophylaxis for PCP. So you would give them Bactrim, and then you discontinue the prophylaxis if the CD4 count becomes more than 200, regardless of the WHO clinical stage. And then for TB, all patients who are starting ART, already on ART and have not received TB preventative therapy should be considered for TB preventative therapy. So before starting, you have to rule out active TB, so screening for symptoms and testing where appropriate. And then every CD4 count is eligible according to the guidelines And then you have to exclude active liver disease, alcohol abuse, or known hypersensitivity to isoniazid. And then you give isoniazid 300 milligram daily for 12 months with pyridoxine. And then, so in terms of psychosocial factors that we need to manage, so the patient has to be counseled extensively before and after the diagnosis is made. We need to explain to them what HIV is, what it does to the body, how it's transmitted, the prognosis, and then explain to them that they still need to use preventative measures, even though they've been diagnosed with the virus, so as to protect other people. So using condoms, and then giving pre-exposure prophylaxis where indicated. So in people who have partners that are not HIV positive and they're trying to have a child, for example, and then also seeking early treatment with sexually transmitted infections and handling any blood cautiously. So then also explain the treatment that you're going to be starting, what it does and what the side effects may be. Counsel on the importance of adherence and the consequences of non-adherence. And then there's still a lot of stigma surrounding the virus. So some people feel like they cannot tell the people, their partners, they cannot tell the people that they live with that they actually have the virus. So then in such people, then you would offer them support groups that are available at most clinics, I think. And then there's also people who fail to accept the diagnosis. And then such patients, you could actually refer them to a psychologist. There's patients who struggle with the idea that it is a death sentence, for example. So those would benefit from psychotherapy. And that is it.
Thank you very much. Very well done. Appreciate it, Libukhang. You've done it all on your own too. So thank you. I'm sure this has been a great learning exercise for you.
Yeah.
If there are any other comments from others, doctor, any of the other family physicians, if they want to add. There were some concerns I had. I'm trying to think of. I think a key problem is that you must understand that HIV treatment has gone through many cycles of evolution since 2008 when it was started as a formal accepted government protocol. And this kind of guideline is there to try and support the management and make it less random, which tends to happen. So please, it is very important that you follow the guidelines. There are challenges with the TLD being the new much better option of HIV management, and that that people are being offered it as first choice, but there are a number of patients who are on it where we are trying to get them switched over if they need or can. So I think understand the nature of this current mess where we are trying to manage HIV better. Sumang, you want to comment? And feel free, Dr. Tulute, Kabir, or Petkova. Sumang, did you want to
Yes,
say something? Yes.
yeah,
Go
I
ahead.
just wanted to ask, I think about two questions, just with regards to the TB, the isoniazid prophylaxis. I think on the slideshow, it said that it's considered for any CD4 count. My thinking is that, is it for at-risk patients where we consider it, or like, is it a voluntary thing, or when would we decide whether we would want to give a patient prophylaxis?
Let me see if any of the other family physicians can answer that. You basically, I think, Libukhang has suggested for 12 months post-diagnosis of ARV, and the question of post-diagnosis of HIV. Any other comments? Dr. Tulute, do you want to add to that? Oh, she's here. Dr. Kabir?
Prof, can I add
yes,
to
go
that?
ahead. Yes, go ahead. Add to that.
Yes.
Would you treat routinely
Normally,
or would
children.
you?
Yes, for INH,
Prophylaxis.
normally when we have children which are below 5 in contact with patients with TB, they have to get it. And then for the CD4 count, which is below 200, we also have to get the patients to be on INH.
I think it's a matter of risk, I think, which is what Dr. Petkova is talking about. So
yes,
if you have an adult who has a contact, even if they have higher levels or higher levels of CD4, you might say, fine, you know what, they're at risk, let me give them that. It also depends on them tolerating the INH. So you'd have to try and manage it. But I think the principle is what you're trying to get at, Sumang, is that not routinely necessarily, but more at-risk patients.
Exactly. But for children below 5, it's definitely.
That's right.
So is there a minimum duration?
Well, 12 months is there as a big, remember that the key point is that if they're at risk, if they're at the outset of their treatment, their immunity might be compromised. You want to build up their immunity, reduce the virus. And that's what you're trying to do with the prophylaxis. Reduce the risks of them picking up TB while you have them beginning treatment. So your question is?
Is there a minimum duration
In
for
other
which
words,
it will
whether
be
you treat them
effective or
12 months.
ineffective?
No, it's not about being effective or ineffective. It's prophylaxis. So the value of the prophylaxis is there in that it does reduce the risks of you getting TB. Now, in terms of what Liu Khang has presented, the guidelines suggest 12 months standard. So I think that's your ballpark. Again, Dr. Petkova has suggested under 5 contact TB, you'd actually say that mandatory. But you have to find the rationale behind it. So I would use that as 12-month standard, but depends on the patient if they tolerate it. So I would do that, use that as my benchmark. Does that seem reasonably enough for you?
Yeah, that's
12
fine.
months. Your question is 12 months of treatment, prophylaxis.
Okay.
Right. Yeah, but it is shown to be beneficial.
All right.
Okay.
Thank you.
All right. And you had a second question, Sumang. You said 2.
Is there time for it?
Say that again. Time.
Is there time? Because I think we still have another presentation.
Oh, you mean time to present? Who's presenting? Is it you? Is there
No,
another?
no, it's not me.
I
I'm
know that
asking,
the
is there
group.
time for another question?
Oh yes,
If
go
there's
ahead. But I
another
think
presentation.
we have another presentation, but the presenters have disappeared. Anna, are you back? I see Anna is on the list, but she kind of disappeared when I gave her permissions to join. So the group that is due to present next is on HIV, opportunistic infections, and some prophylaxis. And it's Ekta Govind, Jason Vermark, and Anna Thomas. So I'm not sure that they are going to present because Anna's disappeared again. Oh, is she there? No, she's here. So Anna, are you ready to present? I gave you the...
Hi, Prof. I'm so sorry. I'd just like to apologize to you and the group in general. We actually had our dates mixed up and we thought we were presenting in March. And Jason and Ekta are currently in the ED working a shift.
Right. Can I suggest, well, there are going to be challenges with catching up because this thing is rather full. So let's see if you can put the presentation together and then we can look at sharing that and then seeing if there's a way you can present it someplace or sometime.
Sure.
But start by sending it to me, and then we'll put it up.
Sure, okay. We'll do. Sorry about that.
Not a problem. Please, guys, do go look at that diary, that schedule. Make sure you got your dates right. You all work it out. If you'll need to swap over, please swap over with others. It's all there, and you can fix it up. Okay, just go and rearrange it, and it should be fine. I think this series, this approach has been working quite well. You've been very adult, very much responsible about taking this on. Just quickly, what has been what is the sort of feeling about how this is working out? So if you want to say, yes, this is working for you, you can go on the reactions and press yes. If you think that what is happening in this Wednesday afternoons is working for you, and if you don't think it's working for you, just put no. Okay, guys, yes or no? Is this working for you? Are the formats right? And then we can just talk to the people who have concerns. Is it working? I'm not seeing any greens. There we are. Thanks, Amy. Others, come find the green yes button and raise it. Otherwise, there's a no. Tell us yes or no.
Nothing to explain. Okay.
If you have a no, please. I mean, it's not a problem. It's completely all right. And we'd want to understand why it's not working for you. So, guys, pick up your hand if you feel it's working for you. If it's not working for you and you'd like to share some thoughts. Go ahead, Ntlantla. Thank you for commenting. And Ntlantla and Yatela, please tell us if you have a challenge. Thanks, guys. Go ahead. Ntlantla? Yeah, go ahead. And then Catherine as well. Ntlantla, you want to speak? Okay, Catherine, you ready? Any thoughts?
No, Prof. I was just agreeing that the format, it does work for us.
All right. Okay, we can always tweak it. I mean, at the end of the day, it's 2 hours. We fought hard to make sure that you get good time, that you get here and you get to do it. So please, if you're having challenges with workspace issues, please talk to us. You're supposed to be here at the hour 2, and we know that you might have to leave at 3. So the presentations are being recorded, so you're not losing out. You can go later and look at the presentation, and all of you can do that. You guys are doing a wonderful work with the presentation. Obviously, there are gaps here and there. It's not a deal. I think it's about learning, and we try to fill up these gaps as you're going along. It's short as well, not much that you can't expect to present everything there is to know about HIV management, but it's important that you think from where you are. In other words, as in the clinic, how I function and how I'm using information, that must be your reflection when you go and learn. What's useful for me in this practice or in my private practice, in this clinic or in private practice? So think about it like that. And if you'll all have that perspective, you'll find your sharing becoming quite useful. Richard, and then Ntlantla. You have your hand up, Richard?
Hi.
Well, Ntlantla, you had your hand up, and then we'll come to you, Richard, if you don't mind. Okay, go ahead.
I'm sorry, I didn't get your question earlier, but I just wanted to say I am
comments.
I am benefiting a lot from what has been going on for the past few weeks, and I'm actually learning a lot. Even today, I learned a lot about when to defer medication. Especially, we always advocate for the start of ART within 7 days, but today she pointed out so many reasons when to defer treatment and start it later.
Libuchang, please share it with the presentations, and guys, it's all there. So the recording, sorry, I should have cut this